Good day, this is Professor Will, CBMD PhD. Today's Monday, May 11th, 2020. It is 6:26:33 seconds a.m. Eastern Standard Time, and this is a continuation of my Corona series. So let's get started here. Which COVID-19 model should we use to make policy decisions? Date, May 7th, 2020. Source, Penn State. Summary. A new process to harness multiple disease models for outbreak management has been developed by the international team of researchers. The team will immediately implement the process to help inform policy decisions for the COVID-19 outbreak. During a disease outbreak, many research groups independently generate models. For example, projecting how the disease will spread, which groups will be impacted most severely, or how implementing a particular management action might affect these dynamics. These models help inform public health policy for managing the outbreak. While most models have strong scientific underpinnings, they often differ greatly in their projections and policy recommendations. This means that policymakers are forced to rely on consensus when it appears, or on a single trusted source of advice, without confidence that their decisions will be the best possible. At the onset of an outbreak, particularly for a new disease, a large amount of information is often unavailable or unknown, and researchers must make decisions about how to incorporate this uncertainty into their models, leading to differing projections. For the COVID-19 outbreak, for example, uncertainty is present in a wide range of areas, from infection rate to details of transmission to the capacity of healthcare systems. The designers of each model bring their perspective and approach to address these uncertainties. In order to improve modeling and analysis of epidemic disease, it is essential to develop protocols that deliberately generate and evaluate valuable individual ideas from across the modeling community. We have identified best practices that allow the synthesis and evaluation of input from multiple modeling groups in an efficient and timely manner. In the three-part process, multiple research groups first create models for specified management scenarios. For example, addressing how caseload would be affected if social isolation measures were lifted this summer, or how the duration of the outbreak would change if students returned to school in the fall. The research groups work independently during this step to encourage a wide range of ideas without prematurely conforming to a certain way of thinking. Then the modeling groups formally discuss their models with each other, an important addition to previous multiple model methods, which allows them to examine why their models might disagree. Finally, the groups work independently again to refine their models, based on the insights from the discussion and comparison stage. After a group discussion and individual model refinement, the modelers are combined into an overall projection for each management strategy, which can be used to help guide risk analysis and policy deliberation. At this stage, methods from the field of decision analysis can allow the decision maker, for example a public health agency, to understand the merits of different management options in the face of the existing uncertainty. Additionally, the combined results can help identify which uncertainty, what pieces of missing information are most critical to learn about in order to improve models and thus improve decision making, providing a way to prioritize research directions. This process allows us to embrace uncertainty rather than hastening to a premature consensus that could derail and deflect management effort. The process encourages a healthy conversation between scientists and decision makers, enabling policy agencies to more effectively achieve their management goals. Even after initial decisions are made, the process can continue as new information about the outbreak and management becomes available. This adaptive management strategy can allow researchers to refine their models and make new predictions as the outbreak progresses. For COVID-19, this process might inform how and when isolation and travel bans are lifted, and if these or other measures might be necessary again in the future. The research team plans to implement this process immediately for COVID-19 by taking advantage of the many research groups already producing models for the current outbreak. The strategy should be easy to implement while producing more robust results from the existing process. The team will share results with the U.S. Centers for Disease Control and Prevention as they are generated. Researchers hope this process actively feeds into policy for the COVID-19 response in the United States. It also provides a framework for future outbreak settings, including emerging diseases and agricultural pest species, and management of epidemic infectious disease, including vaccination strategies and disease surveillance. Immunity of recovered COVID-19 patients can cut risk of expanding economic activity. Date, May 7, 2020. Source, Georgia Institute of Technology. Summary. New modeling of coronavirus behavior suggests that an intervention strategy based on shield immunity could reduce the risk of allowing the higher levels of human interaction needed to support expanded economic activity. The presumed immunity of those who have recovered from the infection could allow them to safely substitute for susceptible people in certain high-contact occupations such as healthcare. Dubbed shield immunity. The anticipated protection against a short-term infection could allow recovered patients to expand their interactions with infected and susceptible people, potentially reducing overall transmission rates when interactions are permitted to expand. New modeling of the virus. Behavior suggests that an intervention strategy based on shield immunity could reduce the risk of allowing the higher levels of human interaction needed to support expanded economic activity. The number of Americans infected by the novel coronavirus is likely much higher than what has been officially reported, and that could be good news for efforts to utilize their presumed immunity to protect the larger community. However, there are two important caveats to this strategy. The first is that the duration of immunity to reinfection by SARS-CoV-2 remains unknown. However, individuals who survived the infections by related viral infections, like SARS, had persistent antibodies for approximately 2 years, and those who survived infection to MERS had evidence of immunity for approximately 3 years. The second issue is that determining on a broad scale who has antibodies that may protect them from the coronavirus will require a level of reliable serological testing not yet available in the United States. Our model describes ways in which serological tests used to identify individuals who have been infected by and recovered from COVID-19 could help both reduce future transmission and foster increased economic engagement. The idea is to think in advance about how identifying recovered individuals could help serve the collective good using information collected on neutralizing antibodies in new ways. The researchers studied the potential impacts of presumed immunity among recovered persons using a computational model of COVID-19 epidemiological dynamics, building upon SEIR, Susceptible Exposed Infectious Recovered Framework. In a population of 10 million citizens, for example, the model predicts that in a worst-case transmission scenario, implementation of an intermediate shielding strategy could help reduce deaths from 71,000 to 58,000, while an enhanced shielding plan could cut deaths from 71,000 to 20,000. The model also suggests that shielding could enhance the effects of social distancing strategies that may remain in place once higher levels of economic activity resume. Identification of individuals who have protective antibodies against the novel coronavirus has begun only recently. Antibody tests are not 100% specific, implying that tests can lead to false positives. However, targeted use of antibody testing in groups with elevated exposure will lead to increases in positive predictive value, even with imperfect tests. Serological antibody test differs from widespread polymerase chain reaction (PCR) testing being done to determine whether people are actively infected with the virus. Among healthcare professionals, serological testing could identify recovered individuals who might then be able to interact with patients with reduced concern for infection. Other recovered individuals could be used to help reduce transmission risk in nursing homes, the food service industry, emergency medical services, grocery stores, retailing, and other essential operations. Across society, the relatively small number of individuals with immunity could substitute for people whose immunity status isn't known, reducing transmission risk for both recovered individuals and those who remain immunologically naive. We want to think about serology as an intervention. Finding out who is immune to the coronavirus could make a big difference in trying to reduce the risk to people who would be vulnerable by interacting with someone who could pass on the disease. Serological testing to identify those with immunity might begin with healthcare workers who may be more likely to have been infected by the coronavirus because of their exposure to infected persons. Because so many infections do not produce the distinctive COVID-19 symptoms, it is likely that many people have recovered from the illness without knowing they've had it, potentially expanding the pool of recovered persons. There may be a deeper pool of individuals who can help within their own fields and other fields of specialization to reduce transmission. The reality is that people within high-contact jobs probably are likely to have a higher incidence of infection than other groups. But using antibody information about individuals would create potential privacy issues and require that those individuals make informed decisions about accepting additional risks for the greater good of the community. What this model says is that if we could identify individuals who are immune, there is a chance that some individuals would not have to reduce their level of interaction with others because that interaction would be less risky. Rather than trying to keep reducing interactions, which is helpful for reducing transmission, but bad for what it does for the economy, we might be able to maintain interactions while reducing the risk combined with other mitigation approaches. Ultimately, addressing the pandemic will require development and mass production of a vaccine that could boost immunity levels beyond 60% in the general population. Until that is available, researchers believe that shield immunity could become part of the approach to the challenge. Until we have a vaccine, we will have to use a combination of strategies to control COVID-19, as shield immunity is potentially one of them. Today, this is Professor Will, CBMD PhD on infectious disease and microbiology. Well, hope everybody's having a great morning so far. I started my day pretty early. Well, hope you enjoyed listening, and take care.